All right, so in the first video, you went through a differential diagnosis test for differentiating shoulder and cervical spine pain. Very often, an underlying cervical cause of shoulder pain is missed, but sometimes it really is the shoulder, right?
Right.
So in that case, a lot of times, clinicians aren't testing the strength of the muscle and the positions that are important to the athletes. If you only test your manual muscle testing here, go ahead and push that into me, right? Internal rotation here, go ahead and push into me here, right? Or turn that way for me. You're doing this, hold here, don't let me push in, right? Don't let me pull out. You're only testing with the arm down here. You're missing a lot of information. Think about where athletes need this stability. If somebody has shoulder pain with bench pressing, their arm is not in that position. If somebody has pain with cleans, jerks, snatches, overhead presses, anywhere where their arm is not by their side and they're generating force, we need to make sure that they have the strength and stability demands in that position. And a lot of times you'll find that people test strong here, and then we get them up into this 90-90 position, or 90 degrees of flexion or 90 degrees of abduction, then they are suddenly a whole lot less stable. So if somebody has pain with bench pressing, hell, if somebody has bicep pain with curls, it can be because they're lacking that dynamic stability from the shoulder, and it's not actually the bicep that's creating that pain. So that's the first part of this, and then we're going to talk about some periscapular muscles that people often overlook or maybe don't test in the best manner. When you're testing the rotators of the shoulder, we want to make sure that it's not my internal rotators versus her external rotators. So we want to get in a position that allows me to use my pecs versus her external rotators. So we're going to hold on to the wrists here, and I'm going to drive my elbows out so I can use my pecs like I'm doing a pec fly versus her external rotators. And we want the patient to generate the force first, and then we overpower them. So, Caitlin, I want you to gently push out into my hands here, keeping your elbows by your side. And if it doesn't hurt, slowly push harder until you're pushing as hard as you can. Go ahead, push, push, push hard, push hard, push hard, push hard, push hard. And then when she's really pushing hard, come on, push, 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 push. And then I'll overpower her. All right, ready? One more time. Go ahead and push. Push as hard as you can. Don't let me move you. Come on, push, 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 push. One more time. Ready? 1, 2, 3. Push, 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 push. Good. I always like to test multiple times so I can see the pattern. I can see if there's fatigue. I can look for fatigue compensations. A lot of times people will still have the internal rotation happen at the same time, but what you'll see is one elbow kind of flares out. And that's a compensation mechanism where that shoulder's actually weaker. But that is the baseline test. What we really want to find out is how are you feeling up here? Go ahead and bring your arms up there for me. So she's going to stay elbows in line with the shoulders, and now I'm going to push her into internal rotation. So I'm not just pushing her hands together, I'm rotating around the axis of the shoulder there. So my elbows need to come up, and then don't let me push down. Hold it, hold it, hold it. Yeah. See the difference there, you guys? So I'm pushing the same here. Go ahead and bring this up. And go ahead and push out. Ready? 1, 2, 3. Hold it, hold it, hold it, hold it. Good. One more time. Ready? 1, 2, 3. Hold it, hold it, hold it. And we'll see her left side, which appeared to be very strong here, is now weak up here, okay? We could also test at 90 degrees of abduction where I stabilize the elbow here, and then I say, hey, don't let me push you down. Hold it, hold it, hold it, hold it, hold it, hold it, hold it. Good. And again, ready? One more time. 1, 2, 3. Hold it, hold it, hold it. Come on. Hold here. Ready? One more time. Ready? 1, 2, 3. Hold it, hold it, hold it. If you guys can see maybe you'll turn around so you can see your lovely struggle faces there. Ready? 1, 2, 3. Hold it, hold it, hold it, hold it, hold it. She's trying to hold it back this time. But it's much weaker. I can feel it. I don't know if you can see it. That's why I like this test, because you can see it at the same time. But if they need to be doing things out to the side, we need to make sure they're strong out there as well. She's actually more weak in the shoulder flexion position than the abducted position. What does that tell us? That tells us that when she's performing dynamic movements, if she's doing push-ups or bench press or clean and jerks, or anything that requires stability away from having her arms by her side, any compensations or pain points that she gets might just be coming from the rotator cuff. You ever seen somebody who bench presses and they have one arm that goes up and the other arm's like, and it struggles? Is that you? Yeah, right? As we're bench pressing, it's because that arm isn't weaker in the pressing motion, it's lacking the proximal stability, and we need to hammer that down in order to help with those things. Moving on from there, we need to take a look at the serratus anterior. The serratus anterior is often overlooked and often tested very poorly. The serratus anterior does so much more than protraction. When people are protracting, you get a whole lot of pec that gets in there as well. Functionally, if you look at the attachments of the serratus anterior, it does protraction, yes, but it also is heavily involved as a force couple with the traps to upwardly rotate the shoulder blade, the scapula. It also will do external rotation and posterior tipping of the scapula. Front rack position, anybody? Heavily involved there. Just when I get in the front rack position and I'm active, I feel my serratus anterior kick up. If you're testing in like the traditional testing method, then you're probably missing a lot of information that's useful for anybody that's lifting overhead. If somebody has pain with lifting overhead, we need to be testing again in those positions. So go ahead and lay down on your back. So if you're testing your serratus anterior, go ahead and punch forward, and you're doing it like this, right? Or they've got long arms, need more leverage, go ahead and bend your elbow. You're testing it, drive up, like this to see what's going on. Like there's a good amount of pec activation that comes in there, but also is the problem that she's having in this capacity. If it's a bench press, push up, maybe if that's relevant, right? Like then that might be a position that we might want to test it in. But there's so much, like her pec is on so much here. It's hard to get real good information. And you might find weakness here, and you can address it, and if it's really weak, you'll find it here. But if her problem is only when she's up overhead, you might find, and this is pretty common, a really strong test here, and you're like, nothing's moving, can't even break it. I'm just kidding. You should always be able to break the things that you're testing. And if you're not getting good information because you have no idea how much strength they have left, right? So better way to test. Go ahead and sit up. When we're testing the serratus, a better way to go about this would be to have somebody go into full elevation of their arm here, palpate the inferior angle of the shoulder blade back here, and then as she elevates her arm, follow it up as it upwardly rotates. It's going to swing anterolaterally, really. And then you can put your thumb right on the now anterior border of the scapula. Right, so we can get her in the full elevation. I think you should come down into about 120 or so there. And I'm going to put a little bit of pressure on her scap here as I'm pressing down on her elbow. What I want to see is when does the scapula downwardly rotate. Ready? 1, 2, 3, hold it, hold it, hold it, and there. Now I feel it downwardly rotate. Notice her arm didn't really move much. Ready? One more time. Come up a little bit more. Ready? 1, 2, 3, hold it, hold it, hold it, and then we get a little bit of arm movement, but that's also when the scap starts to move. And if it's really strong there on both sides, we can always test in this full overhead position, which is where she really needs it. So you might find somebody that tests strong with protraction, that might test strong upwardly rotated here, but when they're fully overhead in that position that they need to be in, ready, 1, 2, 3, hold it, hold it, hold it, it's significantly weaker. When we're testing the serratus, what we want to do is find the inferior angle of the shoulder blade here, and then have Caitlin rotate her arm up and follow it all the way up, so I'm now anterior to it, kind of pushing it. So if I were to push it here, and let me move it, if I were to push it here, we'd be pushing into downward rotation, right? So we're going to have her come all the way up, come down to about 120-ish degrees there, and we can hold and feel the scapula, hold onto the elbow, and say, hey, don't let me move you. Ready? 1, 2, 3, hold it, hold it, hold it, and then find when we feel, ready, one more time, 1, 2, 3, hold it, hold it, hold it, that downward rotation of the scapula starting to happen. Now you can test all the way overhead as well, because she might be okay here And if her position where she has pain is up here and she's weak here, well, imagine that she catches a weight here, all of a sudden has this extra force, and then that shoulder blade downwardly rotates because it can't stabilize here. Of course you're going to get maybe some rotator cuff related pain because it's going to put an inappropriate stress on those tendons. So we can test all the way up overhead, and then don't let me pull down. Ready? 1, 2, 3, hold it, hold it, hold it. And it's much weaker in this position. Ready? 1, 2, 3, hold it. See how quickly this thing starts to downwardly rotate? Versus if I test it here. Ready? 1, 2, 3, hold it, hold it, hold it. It's much, much more stable. Very big difference. So if she has pain with overhead lifting, or she's getting a ton of trap contraction, maybe irritating the neck at some point, then we need to make sure that we're addressing the serratus anterior. If you know there's nothing else going on along the chain, you know, a little lever arm, much easier if you just hold on to the wrist. Ready? 1, 2, 3, hold it, hold it, hold it. And then you can come all the way up here, hold it, right? Go ahead and relax. And that's just because, one, it's a longer lever arm, so you have more mechanical advantage. We want to make sure that we know there's nothing going on in the bicep or anything like that. That's one of the advantages of having this test, right? Is it doesn't involve any of these structures, but if you clear them out, you know that they're not involved, they're not a pain generator, then you can feel free to test that way and get really good information that would otherwise be missed. Looking at the interscapulars here, when somebody lays down, I like to have them a little bit diagonal. A lot of times people will lay right here on the very edge. Caitlin's got a little bit of space here. Move over towards me just a little bit. Right, a lot of times people will lay here like this. The problem with that is, put your arm out to the side, hold it. When I do this, they start to feel pretty unsteady, like their whole body's gonna fall. So we need to make sure that the shoulder itself is hanging off the table, and like Caitlin just did before I told her to, have them move their hips over so they're lying slightly diagonal here. I take my hip, put it up against their hip, and then I'm going to actually add more stability by leaning my forearm along the opposite side of their back there. So now if I were to push here, it doesn't really matter. They're going to feel stable here, and I'm stabilizing their body. Putting my hand here allows me to monitor the upper trap because we want to make sure that we're not getting an upper trap dominated movement as we're trying to test the rhomboids, mid-trap. So what we're going to do here is we're going to start off by making sure she knows the movement that I want her to do. So I'm going to hold on to her shoulder. I'm going to say, hey, Caitlin, let me move you. This is how I'm going to have you move, but you just let me move you first. Boom. Right there, okay? So this is what I'm going to have you do. So now what I want you to do is kind of move with me back there. And if she starts to compensate, I can make some corrections. Say, nope, down here, hold there. Hold it. Good, and then relax. And then move yourself there. All right, and you can see here that her trap is not on, even though she has some nice, well-built, well-defined, meaty traps. Nice job, Caitlin. They're not engaged. So now engage your upper trap. Now we can see, like, all right, this thing is no longer pliable. This thing is on, and that's not what we want. So go ahead and relax. Go ahead and bring that back, right? Feel this working here. And you can go and you can test in a thumbs down position. So go ahead out to the side, keep your elbow straight, kind of bring that arm out to a T, keeping your thumb down, and you'll feel this kind of in here, right? And then if we were to externally rotate her, and you guys can try this, externally rotate in a way that brings this shoulder back with it, so the thumb maybe is even pointing back a little bit here. Now I feel a little bit inferior, right? It's a different muscle. Hold it there, that you're testing that, versus hold there, that. You agree with that? Mm-hmm. You feel it differently, right? Mm-hmm. So if we go thumbs down, we're going to be looking at a little bit more of that rhomboid, right? Yes, they work together, but a little bit more rhomboid. So hold there, right? Make this soft. So come back down, relax everything. Hold here, ready? 1, 2, 3, hold it, hold it, hold it, hold it. So even though her upper trap is on there, we're not getting scapular elevation compensation. So one more time, and show what that looks like. When I come and bring it out here, use that shrug to hold your arm there. Ready? 1, 2, 3, hold it, hold it. So see when I push, now this starts coming up. That would be a failed test because now she's compensating other movement patterns and muscles for the shortcomings of the muscle we're trying to test. So then if we go externally rotated and we have her hold there, now notice this thing is much softer here. Ready? 1, 2, 3, hold it, hold it, hold it, hold it. Whoa, good. One more time. Ready? 1, 2, 3, hold it, hold it, hold it, hold it. Boom. Good. And there's a strength difference there. We can tell that when her thumb is down versus her thumb is up, that we get a different ability to resist the motion. And that's important for what positions you have her training in. Now, if we're looking at the lower trap, it's going to be bringing this shoulder blade back down towards this back pocket. Don't say butt cheek. Don't say, hey, bring this shoulder towards this butt cheek. That's weird. Don't make it weird. Bring this shoulder back towards this back pocket over here. And notice I touch at her hip. I'm not like, hey, bring this shoulder towards this back pocket, right? And then I tell her, I want you to feel it through here. Use this part of your back. Go ahead and bring it back there. Now, key points here are that her arm is straight down towards the ground still. What you're going to see is that people bring their arm and their elbow back, and this is not lower trap. This is lats. You can feel that this sucker is on here, right? So then you got to try to get them to hold here and relax this down, and that's going to be lower trap. And then they've got to hold that position, keep the elbow straight, thumbs up, bring it slowly up into a Y type position, keeping this bad boy off. And we want to be not quite parallel with the floor, right? So below the top of the table, because when you get all the way up here, you're going to get the upper trap. So we give them the benefit of the doubt, give them a little bit of wiggle room, hold there, keep this on, take the weight of your arm. And I just look to see when they take the weight of their arm, do they shrug up? Shrug up for me. If they do this to hold, they've already failed the test, right? They can't even hold the testing position. So they come back down, hold this. And if you're getting that, you can say, hey, let me hold the weight of your arm here. Relax this down. They reset their shoulder blade, right? Hold it, stay tight here, turn this on, right? And I'll take the weight of your arm back. And when I let it go, if we see it stays there, cool, then I can test. If we see that it shrugs up, then they failed. They can't even hold the testing position. So hold here, ready? 1, 2, 3, don't let me push it down, hold it, hold it, hold it, and that's what I'm looking for. When does this thing start to elevate? Ready? 1, 2, 3, hold it, hold it, hold it, hold it, hold it, hold it, and there it goes, right? Arm's not dropping, but scapula's elevating. And we're not testing glenohumeral motion with any of this stuff. We're testing scapular motion, right? Because you could look and say, like, if I'm doing a bodybuilding workout, thumbs down is going to hit posterior deltoid here a lot. Yes, for glenohumeral motion, but we're looking at scapular motion, not glenohumeral motion. When you're prescribing exercise, now you can keep these different positions and principles in mind, right? If they have difficulty or weakness going back with their thumbs pointing backwards, you can modify whatever reverse fly or band pull apart or exercises that you're going to be doing in that position to be specific to the position that they were weak in, right? The hand placement, internal, external rotation, all of that type of stuff. When you find that there's weakness here, you can now start prescribing exercises in that plane of motion that are designed to increase the stability. So wherever you find the weakness, take those same positions you found the weakness in and apply those positions to your exercise prescription, and you're going to get a lot further, a lot faster.